Welcome to Open Source Health, the podcast that doesn't just talk about fixing healthcare, we're actively doing it. I'm Tripp Johnson, CEO of the Advita Collective, and I'm here to take you on a behind-the-scenes journey as we build a technology-forward, stakeholder-centric healthcare company. Our mission? Bring transparency and innovation to an industry that desperately needs both. Join us as we dive into the intersections of policy, technology, and hands-on healthcare, offering a rare glimpse into the challenges and triumphs of creating a system that works for everyone: patients, providers, policymakers, payers, and technologists alike. We'll share our journey of building in the open, and we'll have candid conversations with our team and other like-minded change makers who are as passionate as we are about revolutionizing healthcare. This is Open Source Health, where we don't just diagnose the problems, we roll up our sleeves and work on the solutions. Let's get started. Welcome back from vacation.
Wasn't sure what I was coming back to given the state of things. I was delightfully without too much internet and no cell signal really, and came back to the States and saw there was a manhunt. Given our frustrations and your public frustrations with Blue Cross Blue Shield, I was a little worried someone was going to start accusing you of being the masked assassin, but figured you probably had a little bit of saving grace since you're public vegan and don't believe in killing animals for your proteins.
Yeah, I don't even kill bugs. I move them outside.
Yeah. that may be
I
one of the
got like 37
weirdest...
texts when that happened, and I was like,
really?
Wait, are you guys trying to tell me you think I had some part in this?
Yeah. And then turns out he was a heartthrob or something, so that was probably the telltale sign you were in the clear.
Yeah, exactly. Yeah, that doesn't count to me. Yeah, I was somewhat fascinated by the fact that this guy became such a, again, this is horrible by all accounts too. The CEO of United was just a great human all around too.
Yeah.
And like, there has to be like real separation between like your frustrations with institutions and systemic problems and the people who are in place, because they may be doing their best to make positive changes and you just don't know it. So, obviously, let's just say that all up front to be clear. But then the piece that I did find like particularly interesting was this united the internet in a way that like only Kim Kardashian has in the past.
Yeah.
Or the dress. Like, what color dress do you see?
Yeah. For the Hawk Tuah girl. Something that was interesting to me about this was diving into his reading list a little bit, just looking at some of the stuff. I don't know how true or whatever this is, but like one of the Substacks he followed, the author published some exchanges that they had, and I went in and kind of read the author and some of the stuff he wrote, and then also some of the email exchanges they had. And again, like who knows how true this is, but he seems Assassin Luigi seems somewhat fixated on this idea that we're in a system in which we're all lacking free will and we're just sort of drifting along and no one pays attention, that sort of thing. I think both of us have been on record not exactly believing in free will, and that's like a whole different podcast from this. But it, to highlight your point about the idea of like, hey, this is just a human, right? It's just a human person that's caught up in a system, even if you believe the system is horrifically evil. It's this astounding lack of empathy for the guy's family and for him. This complete lack of nuanced understanding and take on the stuff was really jarring for me in some way that was like uncomfortable and gross. Cause it's like, listen, have you never been really like down the rails on something where something got away from you, you didn't mean it to, momentum was happening, and you look back and you're like, man, the last 5 years, this is not how I'd have loved to have lived my life. If you can even just arrive there mentally and you can connect to that, how could you not have grace or something for someone that's in a system that you consider evil, right?
Well, like the personal example for me was I joined the army because because I thought it was like good versus evil. I wanted to be a good guy. And then I got to Afghanistan and we did a bunch of, crazy shit that like just made me question a lot of things.
Yeah.
I was a part of that. I was mowing down opium fields, getting rid of people's ability to provide for their families, essentially. Yeah. And then on the other side, the real pertinent side to the insurance discussion is like, I have historically been such an advocate for
Right.
working
Yeah.
collaboratively with insurance companies, despite a lot of the frustrations we've had. But there are so many good people in all of these companies. And there are people fighting the good fight internally. And that's what's really important to remember. I
Yeah.
think, some of the stuff I want to get into today and over the next few weeks as we kind of dive more into utilization management and just peeling back some of the layers that make it so opaque, right?
Yeah.
Because people just don't understand how this
Right.
works. And it's my hope with this podcast in general that we shed light on like why things are the way they are. I did actually find it kind of interesting in his manifesto. He said, I know it's a lot more complex, but I don't have time for that. And it's like, yeah, but
Oh,
that's the only way to solve this is like it is a very complex problem.
yeah.
There's no silver bullet. This stuff is just really hard. One of my friends now was a medical director at Blue Cross Blue Shield, North Carolina. One of her really big frustrations before she got booted out a few months ago
Hmm.
was like she was in charge as a medical director. A lot of your job is just this utilization management, making sure
Yeah.
that people are getting what they need to, and also like not abusing the system, because that's the other side of this is insurance isn't all good or bad, and neither are provider
Right.
organizations, right? We've all heard the crazy stories probably about running unnecessary diagnostic labs that cost thousands and
Yep.
thousands of dollars. And then the insurance company has to pay that. So utilization management is where that like the magic should happen, right? And it's very difficult and it needs to be a very thoughtful
Yeah.
process, but it's generally very opaque even to people on the inside of the industry, much less to like patients who their interaction with healthcare is when they go to the doctor.
Yeah. I had this interesting exchange with the jujitsu teammate of mine who's a heart surgeon. He was talking about the Blue Cross decision recently around the anesthesiology and how they were sort of covering that. If people don't know, essentially there was a decision to limit the amount of time someone could provide anesthesia, do this.
Oh yeah.
And so the way that the sort of trade union for anesthesiologists spun this was that they're telling us, we can't keep our patients safe or out of pain during surgery versus, no, actually, really the nuance of this and what's going on is there's a lot of unnecessary prolonging of anesthesia, using these sort of practices, ultimately towards billing the insurance company more and like triggering these sort of larger payments. And there's an incentive structure there for it. Anyway, the heart surgeon, we were talking and someone was kind of railing on this. He's like, well, listen, all hospitals love it when we bring in more money. He's like, yeah, I've known anesthesiologists that prolonged it or did things that they didn't need to do for the sake of making more money, right? You got something, yeah.
Yeah, I got it.
Probably, you've always got
Yeah,
something.
but like that's the case, right? Like, again, it all goes back to aligning incentives. And it's really
Yeah.
difficult to do that. Because it's going to be difficult, you need advocacy on both sides.
Yeah.
It's the same thing. Like it's always really frustrated me at how much insurance companies will pay at an hourly rate for partial hospitalization and intensive outpatient, because that means like an illness has progressed so far, you
Hmm.
require this higher level of care, and now we're going to pay you, $100 an hour per patient in a group setting.
Yeah.
But then for outpatient group therapy, like if we were just going to have an outpatient substance use group, Blue Cross pays us like $19 or $22 per person.
Yeah.
This is one of the things back in the old regime I was trying to say, guys, give us better rates for low level outpatient therapy, and our incentives will be cleaner to treat people at a lower level of care, reducing your overall spending.
Right.
And that's the kind of argument and that's the kind of discussion that we should have if we're taking a stakeholder approach to healthcare. But instead, everything's these sound bites about, the insurance company's evil. They're not allowing
Yeah.
us to use anesthesia. And it's like, it's never that simple.
No. Well, that, again, like in the manifesto, the thing that was most jarring to me about that was the acknowledgement that this is a really nuanced thing that I don't have time to explain. It's like, dude, you shot someone, you killed someone, and over nuance.
Yeah.
I've heard people write that off in different ways. To me, that was like this very jarring, like, because in some ways you can be this very sympathetic character, right? There's a narrative you can spin. You understand why this idea of going after the bad guy or whatever, and someone takes vigilante justice and you, whatever. I've heard a million different justifications for it. It's somewhat easy to be sympathetic to the narrative, but that in that line in particular, right? Like, I know it's not nuanced. It's like, yeah, well, we're acknowledging it's not nuanced, or acknowledging that it's nuanced, and we're also acknowledging that it's nuanced and complicated. Anytime you do something at scale, it becomes increasingly complicated. And life is complicated. You really connected this very quickly to like utilization management. And I found that kind of an interesting perspective. Can you take a few minutes just to talk about utilization management a little more specifically and how you perceive it to connecting to some of the frustrations with insurance?
Well, yeah. I mean, I think the frustrations with insurance is like we pay for insurance, so we expect to go get our health care and it be
Right.
pretty straightforward, like at some level.
Yeah.
Ignoring deductibles, out of pocket, whatever.
Right.
But like at the end of the day, and this is the meta frustration with the insurance system is you have this relationship with your doctor, but then it's the insurance company saying whether or not they're going to pay for treatment that's recommended by your doctor. So it
Yeah.
feels like the insurance company's in the room with you,
Right.
when you're at your visit, be that with a therapist, a doctor, a PA, whatever it is. So utilization management is used to ensure that medically necessary services are happening and covered. So on one side, it's like we need to make sure these are medically necessary. We're not doing unnecessary exploratory surgeries and the insurance company's footing the bill. We're not doing unnecessary diagnostics. And this is really tough stuff because this is utilization management. You cannot have a serious discussion around containing the cost of healthcare, making it more
Exactly.
affordable, without having a discussion about the importance of good utilization management and how criteria is used to establish what is medically necessary. And so,
Yeah.
without going any deeper down just like that rabbit hole, at the end of the day, you have doctors saying, we want to do this sort of care. And part of their incentive, too, is to cover their ass, right? Like the last thing you want is you should have done a MRI and caught something, but you didn't.
Right.
So like usually incentives, usually we're going to ask for more than is necessary, and it should get and it can get cut down a little bit. I mean, that to me is a pretty benevolent view of it. And that's how it should work is, at the end of the day, the first part of utilization management is the prior authorization.
Yeah.
Because basically the prior authorization is when you come in, we assess you, and we say, this is the treatment you need. But the services that we're recommending are considered managed care, which is utilization managed care, meaning that the insurance company needs to authorize it to say that they will pay for it. And that first step being the prior authorization is you come in for the assessment, we send over a bunch of records to the insurance company and ask for authorization to provide a certain service. And for us, I'd say, I don't know the statistics, but I'd say 95% or more of our prior authorizations are approved on the first pass. I would say 99 or 100% are approved on appeal. What that means to me is we're not asking for unnecessary care. That's why we have such a high approval rate. But there are instances like you could think, and I know the people out there doing it, and especially in like outpatient psychiatry, when we talk about like ketamine treatment, things like that, there are a lot of places where people inflate symptomology to get payment for a certain service. And at the end of the day, again, it's just this balancing act.
Yeah.
Because that's the only way to keep costs down, right?
Yeah.
Where that gets more confusing for people is when you see these record profits from insurance companies. That's very hard to stomach that my care got denied and they're making billions of dollars.
Yeah. It's, I think that might be something fun to dig into in a second. One of the things that I think is helpful in the way that I think about this stuff is you have a finite resource, which is healthcare. People don't think of it as a finite resource because it's not something like gold or copper or some sort of tangible object. But the fact of the matter is there's a certain number of providers that have specialties to treat a certain number of issues. They have a limited amount of time and an abundance of people that need them. And so, you hear people say, what about a one payer system or something like that? And again, there's trade-offs with all of this stuff, and that's what you have to acknowledge. What frustrates me is when you listen to people not acknowledge this sort of stuff, right? That there are trade-offs. So one of the things you often hear about of someone in Canada or something like that, and they're on an 18-month wait list for some sort of procedure. Well, the reason for that is there's a finite amount of resources and time, and that means manpower, people to get to that. And so when you talk about utilization management, essentially what that is like a resource allocation piece. Like how do we create and manage this finite resource? I can think over the years as a therapist, the amount of people that wanted to get some sort of residential high-end substance use treatment covered. And it's like, well, yeah, but you don't actually have withdrawal symptoms, or you not to say that you wouldn't benefit from something like this, but yeah, it's understandable that your insurance company is not going to opt to cover this because there's no biological objective data supporting that you need 24/7 wraparound intensive care.
And it's like, it might be what you want.
Right.
And it's unfortunate that we don't always get what we want, but you're welcome to pay out of pocket for it too, which is the unfortunate piece. In that example where it gets frustrating for me is there's so many things you absolutely could be doing that you have access to. You don't need, the Egyptian cotton 500 thread count sheets to make an attempt at getting sober.
Right.
I think what's more disappointing to me, especially in the recent kind of squabbles, going back to the summer, Blue Cross said a lot of the changes that they were making to their prior authorization process, being the front end of utilization management, was they didn't want people going out of network and they didn't want people going out of state. What they ended up doing was punishing providers that were in network and in state.
Mm-hmm.
And making it harder and making a higher administrative burden. Quite frankly, it's disingenuous. Now we're not having a stakeholder approach. Now we are just pitted against each other in a zero-sum game. You are trying to make me expend more resources so that you give me resources in terms of reimbursement. And that's a really bad place for the healthcare system to be, is for it to be a really contentious relationship between providers and insurance companies, because who loses in the end? Patients.
Right. Patients lose in the end on that. It becomes this sort of tit for tat game, right? Like you get denied here, or they drag, or they do whatever. Well, the incentive for us as a company is then to try to force through some pre-authorizations or levels of care that have higher reimbursement than why? Because like we're a business, right? Like we have to make money. I want to get paid. You want to get paid. We have a bunch of staff that want to get paid. So the problem with someone like Blue Cross Blue Shield holding what now, like 300,000 away from us?
They owe us like 300,000 in just the last 3 months.
Yeah, if you think about what that does for us as providers, it incentivizes us to make it up some other way by bumping, so you create this complete tit for tat where it's like, listen, we got to make these ends meet, and they're a business too. They have a finite amount of resources going in and out. Ultimately, in the end, it ends up being bad for the patient, which I would argue at a just human sort of level, it's bad for the providers too, right? Like no one wants to have their patient have a bad experience. All of us got into this sort of stuff because we want to help people. So earlier you mentioned the record profits. So we just talked about how some of the speculation you and I have had, and in particular you in the last weeks about Blue Cross Blue Shield has been they lost a state healthcare plan. If you want to read the tea leaves and play sort of sage and try to make sense of what's happening, it's like, well, there's probably a tremendous loss of revenue coming in as a result of that. So now they're trying to stymie the amount of money going out, aka reimbursements to providers. And you see something like that, and you look at record profits for insurance. I don't know how this would pertain to Blue Cross Blue Shield North Carolina necessarily, but I am curious when we talk about having to preserve resources and those things being finite, how do you maintain all of that?
Yeah, well, let me jump back and also say this is actually maybe one of the more interesting pieces to me, at least. Blue Cross Blue Shield is having record money losses right now.
Yeah.
Now, granted, some of that was due to COVID, and during COVID, a lot of people, well, one, there was some initial cost savings because people weren't getting elective surgeries and whatnot in hospitals. But then after that, you saw a lot of more medical claims, some that were just held over, and then just the proliferation of telehealth. So people were accessing a lot more care.
Yeah.
If you go back, and I don't have their financials in front of me, but I have this on very good record.
Mm-hmm.
There was a time of maybe 4 or 5 years ago where Blue Cross made so much money that they reduced premiums because they were making too much money. That was also around the same time, which is a great thing, right? Like
Right.
they were
Good
making
on
too
them.
much money and they passed it back to the patients, basically.
Yeah.
That's awesome. That's how it should work. Now, what's interesting to me, though, is that's when Blue Cross in North Carolina was at its heyday. They were making record profits and people wanted to be in network with them. It was a rising tide lifts all boats situation for them. Fast forward to now, and they're posting losses every quarter. So they are losing money. And right now, a lot of what they're doing is just trying to slow down the bleeding. Again, I'm trying to read the tea leaves a little bit here, but I think in absence of having a strategy to become that trusted name brand health insurer in the state, like they don't have a strategy to do that. So now they're in a very reactive mode, trying to pinch pennies left and right. And what they're doing is their executive team has been torched. The ones that have remained, I'm pretty sure some of them are going to be on their way out in the next few months. The good ones,
Yeah.
I think the bad ones, who knows? I think it's very likely they will not have jobs in 6 months because it looks like the company itself is suffering from a total lack of leadership. And they are doing things that destroy the trust of those people that are out there fighting the good fight internally at Blue Cross, and also all of the providers and all of the patients out there in North Carolina. So I think what's really interesting is like profitability doesn't have to be bad, and it doesn't have to be bad for the patients, but it has to be like this. It's a super complex system we've got to operate. And so it's all about some balance and homeostasis about what's going to work.
Yeah.
And unfortunately, in the short term, people are always caught in the crosshairs.
Probably a poor choice of words there too.
Oh, yeah. Yeah. Well. So, yeah, I mean, long story short, we need health insurance companies to be solvent, but and the ACA, one of the things that people don't often know is like the ACA capped the amount of money for-profit health insurers can make each year.
Yeah.
So they're not actually trying, but that's based on their revenue, right? So they can only make a certain percentage based on their revenue. So their incentive is actually to continue to grow medical spending.
Yeah.
Just at a certain proportion. Like there
Right.
is a balance, and maybe that the profit margins are too high across the board. But then we see certain companies, really struggling right now. And that's just the whatever crony capitalism, pseudo free market we've got.
Yeah. All right. Anything else? Closing thoughts?
No, I mean, I think we probably should talk more about utilization management in the future, because it's really, for people who are frustrated with healthcare, I would just say, go look up utilization management, see what your rights are as a patient, as a provider organization. If you're outsourcing your billing or some of your prior auths, make sure that the people you're working with are really advocating for what's right. Make sure that you're using standardized batteries so that when you're advocating for a patient, that you're doing it coherently and in a way that doesn't make others look like idiots. Because, we all need to work together to make sure that people get the right care and contain costs.
Perfect. Seems like a good wrapping spot.
Rock and roll.
We need a better sign off.
Yeah.